All right. Blood pressure medications. These are medications that you need to become very familiar with because you'll be given these medicines probably every day of your nursing career. No matter where you work in nursing, you will be dealing with these medicines or helping patients with them in one way or another. So they're good to get to know the basics of them. There's some basic categories or more common categories that we'll talk about. And then there's some other medicines that we're going to cover that you may or may not ever see depending on what venue you work in. But we'll still cover those. They're important to just know the basics of those. As far as hypertension, it's classified in a few different ways. The American Heart Association classifies as normal, stage 1, stage 2, and hypertensive crisis. For our purposes, for this class, just understand the very basics of it. Normal is less than 120/80. Hypertension itself would be usually classified 140 over 90 or greater. Certainly there's pre-hypertensive and stage 1, stage 2 hypertension, but I'm not getting that deep into it. Hypertensive crisis, however, would be SBP over 180. That is something that you need to understand. We need to do something about that. You need to get a hold of the doctor and figure out what we need to do to bring that down. So some contributing factors to hypertension. One, probably the biggest, is just genetics, family history. Another would be diabetes and hyperlipidemia, so certain disease states. Stress is another contributing factor. Smoking, alcohol, obesity, and then African Americans have a higher rate of hypertension as well. As far as treating hypertension, so let's talk about really what are the symptoms. What are the symptoms of hypertension? And then why would we treat it? So a lot of times the symptoms are just nothing, right? Unless it's come on quickly, sometimes that occurs where we become hypertensive, acutely. Then we start to see the headaches, the vision changes, things like that. Or if the hypertension just gets so out of hand, once it gets high enough, you'll start to have those symptoms. But most commonly, hypertension or the blood pressure just gradually climbs, and you don't really even notice it. That's why it's called the silent killer, right? Because the symptoms themselves are vague, if not non-existent for patients, yet the damage that's being done can be marked, can be pretty intense, and potentially cause some chronic illnesses such as heart failure, kidney disease, things like that. So that's why we have to treat it. So the actual symptoms of hypertension and what hypertension is doing to you acutely rarely is anything until we get up into the really high blood pressures. Then you'll start to see those acute symptoms. However, if we allow that, even the mild hypertension, to go on for long periods of time, it increases our risk for big events such as even chronic things like we talked about, heart failure, kidney disease, but also acute cardiac events such as an MI or a CVA. So that's why we got to treat it, right? Not because the acute symptoms of hypertension, but because of the long-term effects of hypertension if we allow that to continue to go on. So what would be the first thing we'd need to do? What's the first line of treatment for hypertension? For most diseases or most processes like this, the first line of defense is almost always, or first line of treatment is almost always lifestyle modifications. Depending on where the person is at with the hypertension or other processes that we'll talk about throughout the semester. A lot of times they'll just try that first and see if maybe making a few lifestyle modifications allows you to control your disease process, and in this case it's hypertension, without the need for medical intervention. That's obviously the best practice if that's possible. However, some people come into the clinic or the doctor's office and they've got marked hypertension. It's the first anyone's noted it. We will definitely still do lifestyle treatment, lifestyle modification treatment. However, those people will probably also need maybe a mild antihypertensive at first, or maybe even a little bit more intense depending on where they're at, along with that. But the first line treatment is always lifestyle modifications. And again, some people, when they come in, when they first are diagnosed, no one had ever noticed it before. Maybe they hadn't been to the doctor in God knows how long, and it's obvious that they've got a problem with hypertension. The doc may have to start with a step 2, which is still, again, your lifestyle modifications, but also a medication. So again, step 1, lifestyle modifications. Step 2 would be your lifestyle modifications continued along with a basic medication. A lot of times it's maybe a diuretic or ACE inhibitor, and then we just keep going from there. Maybe they'll add another medicine if it's not being controlled by just the one, or increase meds, make adjustments in meds. But again, remember, just the first line is always lifestyle modifications. And what do we mean by lifestyle modifications? Well, look back at what our contributing factors were, right? Some of those are non-modifiable, right? You can't do anything about genetics, right? You can't do anything about that. Can't do anything about age. Can't do anything about certain things, but some of them are modifiable. Becoming more active, a better diet, smoking cessation, reducing alcohol, those types of things that, anything that we can modify that would be a contributing factor, certainly is what we would try first. Classifications of medications. These are the meds that we're going to go over during this PowerPoint, and so we'll just keep going. The RAS system. Okay, so the RAS system, renin angiotensin aldosterone system. Understanding this, and we'll go over this in class a little more in depth, but just kind of look at this pictorial here and see how that all associates there. Understanding this will give you the knowledge for the first 3 meds that we'll talk about. It's all based on the RAS system. So our ACE inhibitors, which are one of the most common antihypertensive medicines, ARBs, or angiotensin receptor blockers, and renin inhibitors. Renin inhibitors you don't see as often. There might be some floors that you work that you may see them a little more common than others. But even then, even on those floors, it's still the ACE inhibitors and the ARBs are far more common than the renin inhibitors. But we'll talk about all 3 of them. So first one there is the ACE inhibitor, the angiotensin converting enzyme inhibitor. These are very easy to recognize. I like these. I wish all classifications of medications were so easily recognized. I don't understand the naming process. I believe a lot of times that pharmacists hate us, so they try to make it as impossible to pronounce and understand why this medicine is what it is. But every once in a while, a pharmacist that's putting these things together likes us, so he makes it easy on us. And in this case, this is one of those cases, and it's pril. You're going to know an ACE inhibitor because it ends in pril, lisinopril, captopril, whatever april it is. If it ends in pril, we know it's an ACE inhibitor. So how these meds work. Again, the angiotensin converting enzyme, if we looked at our RAS system, angiotensin you need to convert angiotensin 1 to angiotensin 2, which is done by the angiotensin converting enzyme in order to cause the vasoconstriction. It's just part of the RAS system. If we block that, if we block the angiotensin 1 from becoming angiotensin 2 is the active form, so it's not, if it's never made, if we're able to block it from being made, then those vessels, instead of constricting, they dilate. So instead of causing the vasoconstriction, which an angiotensin 2 does, causes vasoconstriction, it causes the dilation when we don't have the angiotensin 2. And of course that will cause a lower blood pressure. All right, so indications. Primary indication of an ACE inhibitor is hypertension. It's the most common reason why we give these. Other indications are heart failure, more specifically left ventricular heart failure, and diabetic nephropathy. They can protect the kidneys potentially. They can also, though, sometimes cause some kidney issues or some kidney damage, so there may become a time when the risks outweigh the benefits, so we'll keep an eye on that. But those are the most common indications. Again, the number one indication is hypertension. It's the most common reason why you're going to give it, but they are also given for heart failure and given for diabetic nephropathy. Adverse effects, if we look at our indications, the number one indication is hypertension. That is also your primary adverse effect. Your primary adverse effect is hypotension. So if you're giving something for hypertension, just think we can give too much, or their body can respond in a way where it's too effective and they become hypotensive. So just always kind of think of that. What is our primary indications for this medicine? And then that'll a lot of times give you your primary adverse effects, because it's the exact opposite there. So we're giving it for hypertension. It can cause hypotension. With these, the most common form of hypotension you'll see is orthostatic hypotension, but you may see a general hypotension as well, depending on how that patient is reacting to the medicine. So again, primary adverse effect, hypotension. Because we're giving these, our primary indication is hypertension. All right, so adverse effects. Hypotension, secondary persistent dry cough. It's not like everybody gets it, but it is common enough to where you'll need to know it and kind of assess for it. Because if it becomes too persistent, they may need to switch to a more tolerable medication. So not everybody gets it, but if they do get it, we need to let the doc know and maybe switch them to something a little more tolerable. Another secondary adverse effect is hyperkalemia. The way that these affect the aldosterone system can cause us to retain potassium, causing hyperkalemia. I've seen it a couple times in my practice. It's not common. It's not something I see every day at all. It's not something I even see every year, really. But it is something I've definitely seen a couple times, so you just keep an eye on it. That already tells us, we look at those adverse effects, that tells us exactly what we need to know before we give a medicine, right? We're going to check for a couple things. What's their blood pressure? So are they already hypotensive? If they are, we're not going to give it. And what's their potassium? If they're already high, if they've already got hyperkalemia, we're going to hold that and call the doc and see what we need to do about that. We don't want to cause further problems. Another another secondary adverse effect that you will see sometimes, it's again not common at all. It's pretty uncommon, but it does occur, and we need to be aware of it so that we can assess for it, because it can potentially be very dangerous for the person, and that's angioedema. Most commonly, this is going to start around the eyes and the lips. It can also affect the tongue and the throat, and that's when it becomes dangerous. So they need to know to watch for swelling around the lips and the eyes, and if they notice that, they need to call the doctor. If they start having swelling of the tongue and the throat, they need to get emergent help now. Again, it's not common. It's not something that happens every day, but it does happen, so we need to be aware of it, and especially with the fact that it's such a dangerous or potentially dangerous adverse effect. So that's another thing that we would check before we give that medicine. Have they ever had that medicine before? Have they ever had an allergic reaction to it? Have they ever had angioedema reaction to it? Certainly if they have had some angioedema to this medicine or even an ARB, we'd probably go ahead and hold that medicine. Don't give it. Call the doc, see what they want to do. Contraindications. We just talked about angioedema. So if they've had angioedema to ACE inhibitors in the past, or if they've experienced angioedema with ARBs, probably a good idea to go ahead and hold that, call the doctor, and say, hey, what do you want me to do with this? Another contraindication is pregnancy. All the RAS medicines, Renin inhibitors, ACE inhibitors, and ARBs really are contraindicated during pregnancy, especially in the second and third trimester. But they need to be stopped as soon as the patient knows that they're pregnant. Or if they're thinking of becoming pregnant, they need to contact their doctor. And that way the doctor can maybe switch them to something that's going to be a little more friendly to the fetus. There's a potential there for ACE inhibitors or ARBs to cause, or even Renin inhibitors to cause renal damage on the fetus. Interactions. I'm sorry, before I get to interactions, I'm going to talk a little bit about some cautions. And we kind of hit on this a little bit already. We give these medicines for heart failure. However, there can become a time when the heart failure is to an extent where the risks of these medicines outweigh the benefits, at which point these would no longer be, we would be very cautious with giving these. Same with renal impairment. If they already have renal impairment, we need to watch that because there can become a time when the risks now outweigh the benefits. So as we move through this class, there's going to be times when we talk about contraindications and cautions, and you're going to be like, well, my aunt is on this medicine and she's got this disease process that you say is contraindicated. And it's always a risk-benefit thing. And you gotta, the doc is going to weigh what are the benefits of giving this medicine to this patient with this process against the risks and make a decision from there. So you will see these given under those circumstances at times. All this means for us is that we need to make sure we're questioning it. If it's a contraindication, say, is this okay? And then also to alert us that we need to just do this carefully and really watch the patient. There's going to be times when we're going to talk about flat out contraindications where you would just not give it, and we'll talk about those as well. Pregnancy with ACE inhibitors is one of those. I've yet to see a doc say that the benefits outweigh the risks with these. They almost always switch them to a calcium channel blocker. All right, interactions. The most common interaction that they're going to run into is Nsaids. Nsaids are non-steroidal anti-inflammatory drugs. The most common of those being ibuprofen. It's a very common medicine that people take. Naproxen is another one. They're over the counter. There's some that are prescription, and we'll talk about those when we get to Nsaids. But for the most part, with ACE inhibitors, we got to be very careful with Nsaids because that can actually decrease the effectiveness of the ACE inhibitor. So it can decrease the antihypertensive effects. Other things that can potentially interact, we talked about how these can potentially cause hyperkalemia, so we'd watch out for potassium supplements or potassium-sparing diuretics. And then, of course, other antihypertensives because we may further increase the potential for a primary adverse effect of hypotension. Patient teaching. So if we look at what we've learned so far about ACE inhibitors, this really sets up our patient teaching. Look at what our contraindications are, right? Pregnancy. So we will teach the patient, if they're thinking of becoming pregnant or if they find out that they are pregnant, they need to contact their doctor and let them know that they're, on this ACE inhibitor and that they are, pregnant or thinking of becoming pregnant. That way the doctor can talk about options and switch them to something a little more tolerable. Our adverse effects, right? Hypotension. So we need to start teaching them about it. And the most common form of hypotension that you see with this medicine especially is orthostatic. So we're going to teach them to rise slowly. Sit on the side of the bed for a minute before you stand up. Report any dizziness or lightheadedness. We'll also look at our interactions. most common interaction, or the most common med there in the interactions is Nsaids. These are over-the-counter medications. People take them, for headaches and general pains and all kinds of different reasons. So we'll let them know, hey, look, contact your doctor before you start taking Nsaids, especially if you're going to take them regularly, because these can potentially affect how well these ACE inhibitors are working for you, and there may be adjustments that need to be made. And then, of course, if we look at our side effects or our adverse effects, we'll see persistent cough as one, so we'll want to educate them about that. Contact your doctor if you start to notice a persistent cough. You may need to be switched to something that's a little more tolerable. And then the biggest thing that they need to watch for, of course, is facial swelling, swelling of the eyes, swelling of the lips, certainly swelling of the tongue or throat. They need to contact the doctor if they start to notice that swelling in the eyes and lips, and they need to find emergency help if they start to notice swelling in the throat and tongue. Angiotensin II receptor blockers. These are very closely related to ACE inhibitors. If you know ACE inhibitors, you pretty much know everything there's to know about ARBs as well. There's a couple differences. This is another one of those meds that thankfully a very nice pharmacist decided to go ahead and name because they are all sartans. They all end in sartan, S-A-R-T-A-N. So losartan, valsartan, olmesartan, candesartan. There's different sartans. Bottom line is, if it ends in sartan, right, Draco Malfoy sartan. If it ends in sartan, we know it's an ARB. The way this works, so ACE inhibitors worked by inhibiting angiotensin 1 from becoming angiotensin 2. These work, so angiotensin 1 becomes angiotensin 2. Angiotensin 2 is the active form. These work by blocking the receptors that angiotensin 2 binds to cause activation. So the angiotensin 2, the active form of angiotensin, is out there floating around, but it's unable to bind to the receptor sites, so it still causes all the same effects, right? So whether you have no angiotensin 2 or the receptors for angiotensin 2 are blocked, it causes the same basic effects. You are going to, instead of having vasoconstriction, you're going to have vasodilation. It's still going to affect the aldosterone system, so we still have a potential there for some hyperkalemia. And we still have maybe a little bit of diuresis with it. So that's our action. Our indications, same as ACE inhibitors: hypertension, heart failure, diabetic nephropathy. Adverse effects, same: angioedema, hypotension, and we're still going to watch our potassium with these. Contraindications, again, angioedema, pregnancy. Caution, same: renal dysfunction. If they've had angioedema with ACE inhibitors, we already talked about, we're probably not going to give these. We're definitely not going to give them until we talk to the doctor. Interactions. Really a lot of the same interactions. Nsaids, other antihypertensives. We're going to be careful with our potassium medications. So see how these are really very similar to ACE inhibitors, because they work on the same system. They work on the same element there, the angiotensin 2, except ACE inhibitors stop angiotensin 2 from ever being made, whereas these work at the receptors, so they make angiotensin 2 basically inactive. Patient teaching. Very, very similar again. Contact your doctor if you start to notice swelling of the eyes and lips, throat. Let's make sure we're getting immediate help with that. Notify the provider if you're pregnant or thinking of becoming pregnant. Change position slowly. Sit on the side of the bed. Notify your doctor of dizziness or headaches or lightheadedness. And then discuss over-the-counter medications with your doctor. we're watching out for those Nsaids. All right, the last of the RAS medicines that we're going to talk about are renin inhibitors. The one that we're going to talk about that you'll need to know is aliskiren. The way this works is this one works directly on renin. Renin is the first part of the RAS system. It inhibits renin, therefore inhibiting the whole RAS system, so angiotensin 2 is never able to activate. It decreases blood pressure, obviously still works on the aldosterone system, so we'll watch for that hyperkalemia still. So very similar, again, extremely similar to the other two we've talked about because we're still affecting the same system. So indication, we usually give these for hypertension. Adverse effects, the same, hyperkalemia, hypotension, angioedema. Contraindications, pregnancy. So, if you're thinking of becoming pregnant or you do become pregnant, let your doctor know. If you've had angioedema in the past to other RAS medications, we would certainly call the doc. Be careful in people with renal disease. Interactions, same, right? Antihypertensives, potassium, all that stuff. And then patient teaching is very similar as well. One thing that's a little different with these is you do not take these with high-fat foods. That one's a little different. But otherwise, you notify doctor if you become pregnant, notify doctor of facial swelling, rise slowly, sit on the side of the bed, notify doctor of dizziness, lightheadedness, watch OTC medications. So very similar. So those first three meds, if you know one, you know the basics of all three of them. Kind of go back, look over that pictorial of the RAS system, and we'll go over that in class as well, just to kind of really burn that in your head there, because that sets up knowing everything about those first three medicines. All right, so things get a little more difficult here as far as understanding or memorizing the names of the medicines. If you look here, the examples of calcium channel blockers is diltiazem and amlodipine, right? There's other ones like verapamil and nifedipine. I mean, there's no real rhyme or reason to why these are named the way they are as far as helping us remember that, oh yeah, that's a calcium channel blocker. Unlike the others where we know April is your ACE inhibitor, we know a sartan is your ARB. Calcium channel blockers, you just kind of need to know diltiazem is a calcium channel blocker. Amlodipine is a calcium channel blocker. There are others. Those are the two that I'm going to have you responsible for knowing. As long as you get the basics down of calcium channel blockers, though, you'll be able to look up a med and go, oh, it's a CCB. I know the basics of that. So, again, with most of these meds, I'm just going to give you a couple that you're responsible for knowing. And then whenever you're looking them up, you'll be able to say, oh, that's a calcium channel blocker. I know what I need to know about that medicine. The way these work, they inhibit calcium ions from getting into the cardiac and arterial muscle cells. Calcium ions are needed for constriction of those vessels and those in the heart, right? So if we decrease the amount that are getting in there, then we're going to open those vessels up, and we're also going to slow the, or not slow, but decrease the contractility of the heart. Actually, it does slow the heart, but that's because, again, it's not contracting quite as much. So it does decrease the contractility of the heart, so decreases contractility and dilates those vessels. And that's how these work. Luckily, it doesn't block them all. It doesn't block them permanently, because otherwise that would be a very, very bad thing. Adverse effects. First one, let's talk about indications first. Indications, hypertension is primary. Another indication, though, is angina. So we do take these to help because these can decrease the heart's need for oxygen, which will then decrease angina. and then also are taken for atrial arrhythmias. So indications are hypertension, angina, and atrial arrhythmias. Now, adverse effects, if we look at our indications, that will tell us a lot about our adverse effects. Number one indication, hypertension. So these can cause hypotension. We also take these for arrhythmias, atrial arrhythmias primarily. If you give it for an arrhythmia, it can potentially cause an arrhythmia. Always think that. That's one of those things that we need to burn in our heads. If we're giving a medicine for an arrhythmia, we need to watch their rhythm because it can cause an arrhythmia. If you're giving it PO, they probably are on telly, but if they're not, we know we're just going to do some good assessment of the heart and make sure that they're staying stable. If we're giving this IV, if you're ever giving a medicine IV that is a potential antiarrhythmic medicine or that we're taking for an arrhythmia, they have to be on a monitor. They have to 100% be on a monitor because of the potential for that arrhythmia. So PO, we're certainly gonna assess and watch, and they're probably on telly. And if not, that does occur sometimes. But make sure that we're watching and paying attention to the heart and looking for any arrhythmias. If we're giving it IV, they have to be on a monitor. I've seen it multiple times where a patient has an order for maybe a CCB or a beta blocker IV to help with a hypertensive crisis. So their blood pressure is like 200, and the doc's like, "Hey man, give them some diltiazem or give them whatever IV to help with that." You still have to have them on a monitor. I know that you're giving it for the blood pressure, but the bottom line is there's a potential for and causing an arrhythmia because it is an antiarrhythmic medication. You have to make sure they're on a monitor. So again, adverse effects, hypotension is most common, arrhythmia, and of those arrhythmias, bradycardia is the most common. So we're always going to check heart rate before we give these. So before you give these medications, you're looking for bradycardia and hypotension. Another potential adverse effect of these medicines, so again, these things can decrease the myocardial contractility, so the heart's not pumping quite as hard as it has been. When that happens, sometimes we get a little bit of fluid buildup, especially in the lower extremities. So you may see a little peripheral edema. If that gets out of hand, obviously they need to contact their doctor. If they start noticing it and it's getting marked, they'll need to contact the doc and get this potentially changed or the dose changed or whatnot. But there is a potential there for peripheral edema. So again, adverse effects, hypotension, arrhythmias, bradycardia, so heart rate less than 60, and peripheral edema. When you're checking for bradycardia before giving a medicine, usually if it's less than 60, look at your orders. The doc may give you an order and say, hey, this medicine's okay to give to a heart rate down to 55. Anything less than 55, call me. Or he may even say lower. I don't know. I've seen some, usually it's 55. However, if there's not an order there and it's less than 60, I'm calling the doc before I give it. Just keep that in mind. So anything less than 60, call the doctor unless you have another standing order that tells you otherwise. Because you've already have the order standing, then fine. Then you're good to give as long as it meets the criteria of that standing order. Otherwise, pulse less than 60, call them. Contraindications, well, again, bradycardia. Anything less than 60, I'm being very cautious with it, and I'm going to look and see if I've got an order. Sometimes the doc will be like, no, it's totally cool to go down to 55. If not, I'm calling the doc. I'm not giving it. Heart block, and again, heart block is going to give us that bradycardia usually, and then severe heart failure. So think about that. With a CCB, we are decreasing myocardial contractility. Sometimes with heart failure, because heart failure just means the heart's not pumping as efficiently, we need to actually increase myocardial contractility. It's not something that we do immediately. A lot of times it's something that we do a little bit later in heart failure, depending on where they come in with the heart failure in the system. Sometimes we need to give a medicine which is the exact opposite of CCB, which we'll talk about here in a little bit, to increase contractility, at which point this would be contraindicated. So in severe heart failure or certain stages of heart failure, we do not want to give a calcium channel blocker. Be careful with people with renal dysfunction or even hepatic dysfunction. These are metabolized by the liver, so that can affect metabolism. And then, of course, with renal excretion, we may affect excretion, so they may stay in the body longer. And then, of course, be careful. Anyone with any type of heart failure, we're going to kind of be careful because, again, we're decreasing contractility. We could further exacerbate those symptoms of heart failure. I'm not going to say you're not going to see somebody with heart failure that's also on CCBs, that you're going to see it from time to time. All you need to know is be careful. And then if you start noticing that the heart failure is exacerbating or getting worse, contact the doc before you continue with the CCBs and see if this is still indicated. Interactions. These can interact with any other antihypertensive, any other medicine that slows heart rate, such as digoxin, beta blockers. These also interact with digoxin because of the fact that, well, digoxin actually forces calcium into those cardiac cells to increase myocardial contractility, whereas these slow or inhibit calcium from getting into the cardiac cells there, decreasing myocardial contractility. So there's an interaction there. These also interact with grapefruit juice. Grapefruit juice can decrease the clearance of CCBs. We talked about grapefruit juice with our last PowerPoint. This is one of those meds that can interact with grapefruit juice, and this CCB can become toxic when you're taking them with grapefruit juice. Patient teaching. Obviously, we just talked about grapefruit juice, so don't drink grapefruit juice, which I think, honestly, if we think about it, that's just a good life lesson overall, because grapefruit juice is kind of nasty. I mean, grapefruit's okay. When I was a kid, my dad used to put grapefruits in the refrigerator, and then he'd cut them in half and sprinkle sugar on them, and we'd, watch Gomer Pyle or something while we ate it, and it was good. It was fine. I still do that from time to time, probably for reminiscent reasons more than anything. But man, grapefruit juice itself just kind of tastes like vomit. But anyways, I'm not, if you're a grapefruit juice drinker, by God, I'll, enjoy it, love it, go for it. I just think it's nasty. So don't drink grapefruit juice though. If your doc says, hey dude, you need this calcium channel blocker, now you know. Unfortunately, the love you have for grapefruit juice is probably going to have to cease. We'll also inform them of course, we're watching for hypotension, so rise slowly, all of that stuff with these hypotensive medications. This one can potentially cause some of that edema in the lower extremities, so we'll warn them about that. We'll teach them about that, and then we'll teach them about why they're taking it, because a lot of people may think of a CCB as only an antihypertensive because it's very commonly given for antihypertensive purposes. However, they may not be taking it for that. They may be taking it for angina, or they may be taking it for their abnormal heart rhythm. So we'll want to educate them on that. Like, this is the reason why you're taking it. You're not taking, obviously, yes, your blood pressure is okay, but you're having these angina episodes. They're going to hope to control that with this, or, whatever reason they're taking it, you're going to educate them on that. Vasodilators. These drugs are commonly for severe hypertension. The way they work is these actually go straight to vascular smooth muscle and cause vasodilation. That's just how they work. They go to the vessels, causing that vasodilation. Obviously, that direct vasodilation is going to cause a decrease in blood pressure, and it's usually pretty quickly. So these are definitely going to lead to potentially orthostatic hypotension, and all the symptoms that are involved there. primarily speaking, the lightheadedness, maybe even a headache because of the fact that these work pretty quickly. So that's our indication, severe hypertension. A lot of these are given IV. Nitroprusside actually is IV only. Hydralazine, very common to give hydralazine IV. You may even give it IM. Sometimes, though, people, they have such marked hypertension that we're giving these PO as part of their regimen. It's not the most common, though. It does occur. It does occur. So I don't want you to think it doesn't ever occur. It does. But usually these are for cases of severe hypertension. Adverse effects. Well, look at why we're giving it. We're giving it for hypertension, so these can cause hypotension. What goes along with that? What goes along with decreasing blood pressure, especially when you do it so quickly? Because these are going to do it quickly, especially when you're giving it IV, right? We're going to cause it to go down quickly. If you think about how your body's going to react, your body's going to try to compensate for that cardiac output. It's going to increase your heart rate, so tachycardia. So hypotension, tachycardia, along with that, other adverse effects that you see directly related to that lowering the blood pressure so quickly, dizziness and headache. Those are really the most common things you're going to see with this medicine. You may see some GI upset. Almost any medicine can cause GI upset, though, just the way that, especially when you're taking them PO. And then with nitroprusside, this is a little different. This is kind of, this will take you back a little bit. You're like, really? But with nitroprusside, when we're given that medicine, the way that it's broken down in the body can actually lead to making cyanide. And if you're getting enough of it for a long enough time, we may end up with cyanide toxicity. Your body can stand so much cyanide, but obviously if we get too much, it can lead to cyanide toxicity. Which with that, what you'll start to see is acidosis. With that acidosis, you'll see the respiratory distress. It eventually can cause respiratory arrest and coma. Obviously, very big deal. So watch for tachycardia. Watch for mental status changes. That'll be some of those early symptoms. Also, an almond odor in the breath. I've, working in ER, I put people on nitroprusside quite a few times, never had to deal with cyanide toxicity. Usually we've either gotten them off of it or sent them upstairs before that could ever happen anyways. But it's possible. So always just watch for that. Whenever you see nitroprusside ordered IV, just keep an eye on that. It's not like it's something that's super common. If you work in ICU, you may be a little more acutely aware of it because they may be on the nitroprusside longer than in other areas of the hospital. So just watch again. Almond, odor in the breath, tachycardia, mental status changes. Obviously, hopefully we would catch that before coma and death. That's the goal anyways. Contraindication, if they are not getting enough cerebral perfusion for an injury or for whatever reason, the brain's not getting enough perfusion, the last thing you want to do, even if they're hypertensive, you want to keep them hypertensive because of the fact that their brain may not be getting that cerebral perfusion. You would not want to give them a vasodilator because that will, again, immediately cause vasodilation and decrease in cerebral perfusion, which can be a big deal. Be careful in people with heart failure, coronary artery disease, and tachycardia. So if they've already got tachycardia, we need to let the doc know, say, hey, look, I know you've ordered this, but they're having, the heart rate's already 110. What do you want to do? What do you want to do? So don't just give it. Just make sure you contact the doc and question and make sure we're okay giving it. Interactions. Any other antihypertensive medicine can potentially interact with it, obviously causing problems with hypotension. And another thing you'll want to check before you give these medicines are erectile dysfunction medications. So don't think, though, that only men are taking those. The traditional erectile dysfunction medicines like sildenafil, also known as Viagra, that is given for other reasons. It's not only for erectile dysfunction. It's the most common reason. It's the reason we most associate with those medicines, but there's other reasons. Also, there are clinics and doctors out there that are giving them to females for female sexual dysfunction. So it's possible. It's possible that a female took it. So all you need to do is just ask, hey, have you taken any, any sildenafil or erectile dysfunction medicines before you give them this? Because if the way that those interact with vasodilators it can be tragic. They can cause extreme hypotension, like dangerous hypotension. Patient teaching with this medicine, again, we're watching out for hypotension. You'll see orthostatic hypotension pretty bad with these. So, report any dizziness, headaches, definitely stand slowly. In fact, if I'm giving this IV in the ER, the hospital, whatever, I'm going to tell them they can't get up without assistance. So I'm going to put the bed alarm on, and I'm going to give them their call light and tell them they have to call me because of the potential for these. No matter how stable they think they are on their feet, these can cause orthostatic changes that will cause them to fall. So I'm going to sit them on the side of the bed for a few minutes. So we'll sit them up slowly, sit them on the side of the bed, stand them up slowly. I've got a gait belt on them. I'm doing all those things. We'll warn them to notify the provider if they start noticing a fast pounding heart rate. And then, of course, if they're going to go home on these medicines, we need to warn them that they can no longer take their ED medications if they're taking this medicine, because it can cause severe life-threatening hypotension. So hypotension. We've talked a lot about hypertension. Let's talk a little bit about hypotension and how we can help with that. Hypotension is obviously decreased blood pressure. Usually an SBP less than 100 is considered hypotension. What occurs there is your tissues may not be getting enough oxygenated blood, right? If we're not pushing the blood through the veins well enough at enough pressure, then potentially we could cause some deoxygenation there. That can damage organ systems like the heart. It can lead to, it can damage other systems as well. Possible causes, severe blood loss. That's probably the most common as far as this being severe. Severe blood loss or dehydration. Effects of medications. We've already talked about antihypertensive medicines. Those can cause hypotension, and they can sometimes cause severe hypotension depending on how much they've taken or their body's response to the medicines. Extreme stress can actually sometimes cause hypotension. I know we relate stress primarily with hypertension, but there's a process there where when it's extreme stress of the way the body responds, potentially hypotension can be a problem. And then, of course, if your heart is damaged enough, like with an MI or by certain types of medications that can be cardio adverse, that damaged heart muscle, of course, if it's not pumping well enough, can cause hypotension. Orthostatic hypotension, that is just blood pressure decreasing from when you move positions, when you move from a lying to a sitting, or from a sitting to a standing position, your blood pressure drops. It's usually by 20 it would be the definition. I think it's 20 SBP or 10 DBP. And you'll also look at heart rate with that. So sometimes you'll be asked to do orthostatic checks. All that means is you're going to check blood pressure laying down, then you're going to sit them up, check blood pressure, then you're going to stand them up. Anytime you're going to do orthostatic blood pressure checks, always make sure you got a gait belt on them and you're ready to catch them, because when they sit or go from sitting to standing, they could easily fall. So always make sure of that. So one medicine that we do use sometimes for hypotension, most specifically orthostatic hypotension, is Mitodryn. If the hypotension is severe enough, that can become shock, at which point we'll need some much bigger medicines, and we'll talk about those in a minute. This is really for orthostatic hypotension primarily. Also, maybe some symptomatic treatment for hypotension, the dizziness, things like that. We'll take this as well. The way this works is it activates alpha receptors that increases vascular tone and blood pressure. Adverse effects. So we're taking this for orthostatic hypotension. So our adverse effect is hypertension, right? We're taking it for hypo. It can cause hyper. It can also cause bradycardia, and some people complain of rash and itching or pruritus. So that's potential adverse effects of these medicines. This would be contraindication or contraindicated if they have hypertension, and you would be like, well, that's obvious because they're giving it for hypo, so why would they take it? Sometimes people will have what's called supine hypertension. So when they're lying down, they're hypertensive, right? But when they sit up and stand up, maybe it's for their rights, I don't know, maybe they're big Bob Marley fans, but whatever, when they sit up on the side of the bed and then stand up, their blood pressure may drop. We still wouldn't want to give them this med because of the fact that they're hypertensive lying down. This will increase the risk for severe hypertension at that point. We'd also would not want to give this if they have urinary retention, because we can further exacerbate that. And be really careful with people with renal disease. Be careful with people with diabetes as well. Interactions. Cardiac glycosides, that's just a fancy word for digoxin. Beta blockers, corticosteroids, which we'll talk about here in a little bit, and then other alpha medications, which we'll talk about as we go through the program. Patient teaching. Usually, if you're going to take this multiple times through the day, you don't want to take it right before bed. You usually want to take it about 3 to 4 hours before bed. Because of its effect on the urinary system. Also, notify provider of signs of elevated blood pressure. So if they start noticing headache and all that, contact the doc. They can also be taught how to take their blood pressure, maybe get a little blood pressure machine at home, and then discuss over-the-counter medications. So that's Mitodryn. Talk about adrenergic blocking antagonists. The most common adrenergic blockers are your beta blockers. This is dealing with your sympathetic nervous system. The biogenic amines that are most commonly associated with that, the hormones most associated with that is your norepinephrine and your epinephrine. And then we're worried about alpha and beta receptors. We're going to talk about some alpha drugs, and then we'll talk about most common ones that you're going to see are beta drugs. There is one alpha drug there's a couple alpha drugs that are still fairly common, so we will talk about those. But the beta blockers are the ones that you'll see probably most often, if not every single day of your nursing career, depending on where you work. So again, we talked about alpha and beta receptors. So here's just a little bit about those receptors. This isn't everything that an alpha receptor are responsible for. And when we get to the beta receptors, it's not everything that those receptors are responsible for, but it's the big stuff, and it will help us understand the medicines we're going to talk about. So alpha 1, if we look there, vasoconstriction, right? So that already tells us if we give an alpha blocker, that's going to cause vasodilation, so decreasing blood pressure. If we give an alpha agonist, one that actually increases the activation of those receptors, that's going to cause further vasoconstriction, increasing blood pressure, right? So alpha 1, those receptors are responsible for vasoconstriction. They're also responsible for closure of the urinary bladder and the urinary sphincter and really the muscles of the urinary system. If we know that alpha 1 is responsible for those, for that system, if we block it, we will increase the potential for urination, right? So because it will relax those muscles and relax that, so it will help the person urinate, especially people with like BPH and urinary retention. So we give alpha 1 blockers sometimes for BPH and urinary retention. Most commonly is Tamsulosin. We actually don't talk directly about Tamsulosin until probably the last class of the semester, but that is an alpha 1 blocker. And then also pupil dilation. So sometimes we give an alpha agonist to cause that pupil dilation. And sometimes we give it for the exact opposite, or a blocker for the exact opposite. Alpha 2 receptors. These help modulate the release of norepinephrine. So what these do is they prevent overstimulation, right? Because your body would just keep dumping norepinephrine, right? And if we keep doing that, we're going to continue to stimulate the sympathetic nervous system. And then if we don't regulate it, you're going to be overstimulated and you're going to be completely dysfunctional and probably with dramatically horrible, untoward problems, right? Or terrible events. So we need to we want to stimulate it, but we don't want to go crazy here. And your alpha 2 receptor is like, oh, okay, we're gonna slow this down a little bit. That comes into practice with one of the medicines we're going to talk about later. Clonidine helps regulate that, or helps increase the regulation of that norepinephrine through the alpha 2. Beta. So the two beta receptors we're going to talk about is beta 1 and beta 2. Beta 1 causes, so when that is activated, it causes increased heart rate and increased myocardial contractility. Because remember, this is SNS. So if we think about those alpha receptors, when we're in fight or flight, when we're ready to either fight or run, which I'm more of a run guy. I'm probably a little more interested in saying, yeah, I need to figure out where I need to run. I'm not that big, so I'm probably not going to fight. I'll leave that to people who are probably a little bit better at that than I am. But anyways, when I'm ready to run, my pupils need to dilate so I can have a better field of vision. My blood pressure needs to go up so that my skeletal muscles get the good, the oxygenation they need to perform at a higher level. My heart rate needs to go up in order to continue that, to get that blood, flowing at a higher level so I can function. So my heart's going to pump a little harder. It's going to, my blood pressure is going to go up. My eyes are going to dilate. All that's going to happen. And then, of course, I'm going to close my urinary area because I don't care. My GI and urinary can be closed off because at this moment, I don't need to worry about stopping to pee or poop or whatever, right? I just need to get the heck out of there, or God forbid have to fight whatever's coming at me. And if that's the case, God help me and whoever I'm trying to defend. Beta 1, increased heart rate, increased myocardial contractility. If we block a beta 1, we're going to have a decreased heart rate. We're going to have a decreased myocardial contractility. Beta 2, now SNS, again, fight or flight. I need to get some good big breaths in there, and I need to get as much air and oxygen into my system so that my system can carry all that good oxygen to all my cells so I can be ready to fight or flight, right? So I'm going to have a dilation of those bronchi, and that's what beta 2 does. Activation of that system causes a dilation of bronchi. Relaxation of the detrusor muscle in the urinary bladder, decreased GI activity, because again, fight or flight, I don't care about my GI at this moment. And then dilation of smaller arteries. Here's the thing, don't worry so much about that dilation of smaller arteries. Don't worry so much about that, because it's such a small amount of dilation. It's not, your blood pressure is still going up, even despite that small amount of dilation in those. You're having constriction of the bigger vessels that's causing increased blood pressure. All right, so beta 2, dilation of bronchi is the big one with that you need to think about as far as these receptors go. So the other ones, that's fine to understand, see how there's different things that are affected, but the one that really I care that you understand with beta 2 is dilation of bronchi. All right, beta blockers. You will know a beta blocker by ending in LOL. If it ends in LOL, you know it blocks betas. Now, here's the thing. It ends in LOL. Sometimes it's selective, sometimes it's non-selective, sometimes it's a selective beta, sometimes it's non-selective beta, right? These ones, the first ones we're talking about, labetalol and carvedilol, they're non-selective across the whole spectrum of adrenergic agents, or adrenergic receptors. That's your alpha 1, alpha 2, beta 1, and beta 2. So that's it. They block both alpha and beta adrenergic receptors, and that decreases blood pressure, decreases heart rate. And the reason we give these is hypertension and heart failure. Adverse effects. So we're giving them for hypertension. They can cause hypotension. Another common adverse effect with these medicines is bradycardia. With any time you see LOL on a medicine, just know I have to check blood pressure and I have to check heart rate. Heart rate is most concerning because anything less than 60, we need permission to give, so we don't give it. This is kind of like a CCB in the fact that every once in a while a doc will be like, no, dude, you're totally cool to go down to 55. If they've already written that order, then I've got that order. The doc is okay, we're good to go. If I don't have that order and it's less than 60, I'm going to call the doc. Even if I know that doc is always like, oh, yeah, we're good to 55. He didn't write the order. I'm not going to give it until I've got a specific order for it because, again, standards dictate that anything less than 60 with a beta blocker, we need to be careful. We need to take special precautions. And my special precaution is calling the doctor and saying, hey, where do you want to go with this? Other adverse effects, sometimes some fatigue, some dizziness. Contraindication, bradycardia. So we're always going to check heart rate. Also would be contraindicated in hypotension to an extent. You will still see these given sometimes with an SPP less than 100. However, I'm always going to ask the doctor, hey man, is this okay? A lot of times they're given these to control that heart rate, but I'm not going to give it. If it's less than 110, I'm like, I need to look and see where they've been. If they've traditionally been there, then I'm probably okay. But I'm already thinking maybe I should call the doc just to be careful. Less than 100, I'm definitely calling the doc. Contraindicated in heart block, which goes, pretty hand in hand with your bradycardia. And then asthma. This is a big thing to understand. This is big. I'm not going to say you're not going to see somebody with asthma that's also on a non-selective. It does occur from time to time. But if they're in an active asthmatic state or active shortness of breath, you would not give this. Anybody that has asthma, we need to be very careful with, because if they do become active, think about that. We are blocking beta 2. Anytime you block the beta 2 receptor, we're blocking bronchial dilation. If they get themselves into a situation where they're having an asthma attack, last thing we want to do is block that bronchodilation. We want to stimulate bronchodilation. So we would be extraordinarily careful. That's why it's called a contraindication. I'm not saying that every once in a while you might not see it. You might see someone with COPD or asthma that's on one of these, but we know we got to be extremely careful and make sure that they're not in a current state of shortness of breath. And then even then, I'm probably going to talk to the doc just to make sure that that everyone's on the same page, that everyone's cool with what's going on. Be careful with people with diabetes. These can affect diabetic medications, and that also one of the more concerning issues is these can block symptoms, traditional symptoms of hypoglycemia. So a person that's diabetic is very attuned to their body usually, and they know when they're starting to get low that they need to take care of it. So maybe they don't check their blood sugar as often as maybe they're supposed to, or because they've become pretty in tune to when they're high or when they're low. However, if they're going to be started on a beta blocker, they need to understand those symptoms that they're looking for, sometimes that they're feeling, those symptoms may be blocked by this, and they may not notice it. And by the time they notice it, it might be too late for them to do anything about it. Somebody with them is going to have to do something about it before it's really, really too late. So that's the importance with diabetes. It can certainly mess with the hyperglycemia, but most importantly, it can mask those symptoms of hypoglycemia, and that is a big deal. Interactions. Of course, any other antihypertensive medication we could potentially cause further exacerbation or further hypotension. And then diabetic medications, like I said before, it can sometimes interact with some of those. And then, of course, beta agonists, which we'll talk about, both alpha and beta agonists we'll talk about later. Those are potential interactions. Patient teaching. Well, it's a good idea for them to understand how to check their pulse. If they start having some of those symptoms like lightheadedness, dizziness, they need to be able to see if their pulse is too low, and they can contact their doctor. Avoid sudden changes in position for the potential for hypotension and orthostatic hypotension. And do not stop abruptly. The problem with that is we can have rebound problems. So if you've been taking it for a while and then you just all of a sudden stop taking it, you can have some rebound, severe like hypertension and some rebound problems. So don't stop abruptly. Call your doctor and come up with a plan if you need to stop it. That was patient teaching. I was supposed to cover that on this slide, but you got the information there. I think we're golden. Again, with the patient teaching, don't stop abruptly. Avoid sudden changes in position. It's probably not a bad idea to teach them how to take their pulse either. Alpha-1 selective blocking agents. So we talked about alpha-1. Again, those can cause vasoconstriction, right? And they can also cause the urinary bladder closure and urinary muscle closure. So for these, we usually use for vasodilation, right? So if we're blocking it instead of constriction, we're going to cause vasodilation, which will decrease blood pressure. Another reason we give alpha-1 selective blocking agents, such as Tamsulosin, which I know that's not on this screen. We'll get to that with our last class, but I'm going to talk about it here because it will help you understand these medicines, is Tamsulosin is a BPH medicine, helps improve urine flow, right? So we use that for BPH, but we also use it for, any sort of urinary retention. So just because females can sometimes be on this as well. Obviously, females don't have prostates, but sometimes they're taking Tamsulosin for bladder relaxation because they're having urinary retention. Those are the reasons why we take it. Indications, that's our indications, BPH and hypertension. Adverse reactions, hypotension obviously is a potential adverse reaction, and that when you take the medicine for BPH, it's usually a small dose, and you don't always see hypotension with that, but there's still the potential there, so you'll check. But if you're giving them for hypertension, it's usually a larger dose, and certainly hypotension is a potential primary adverse reaction. Contraindicated in hypotension, so we wouldn't want to give it then. We would be really careful in people with renal insufficiency because we can exacerbate those issues if we continue to lower the blood pressure potentially. People with angina we'd be kind of careful with, and the elderly. But you will see these given quite commonly in the elderly. Interactions, other antihypertensives, and then nitroglycerin. It can potentially cause some increased hypotensive effects with those medicines. Patient teaching. Again, if you've been on these for a while, do not stop abruptly because we can cause some rebound effects, some rebound hypertension. And then, of course, we'll tell them about the potential for hypotension, so watch out for dizziness, lightheadedness, and stand slowly, all of that stuff that we've already talked about. All right, beta-adrenergic blocking agents, again, beta blockers. So we talked about non-selective adrenergic blocking agents, and they end in LOL. And I get it. Those non-selective adrenergic blocking agents, don't get too confused by all this. There are different types, and we kind of need to understand a few things about them. But the big thing to remember is if it ends in LOL, it blocks beta. Whether it's selective or non-selective, it doesn't matter. It blocks beta. And with that, we know we have to check blood pressure and we have to check pulse, and we're very, very concerned about that pulse. Another thing that is extremely concerning that we need to take into account is, do they have a history of asthma and COPD, right? Because we're worried about that beta 2. Anytime you see LOL, just think those 3 things. First things to think, pulse, and then second, blood pressure, third, asthma and COPD. Always think those 3 things and you'll be fine. There are beta blockers that are more safe for people with COPD and asthma, and we'll talk about those in a minute. But always think those 3 things. So don't get so confused with all these stupid terms like non-selective adrenergic blocking agent, selective not adrenergic blocking agent, blah, 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 adrenergic, this adrenergic, that adrenergic, who cares? If it ends in LOL, you know it's blocking beta somehow. Whether it blocks all of them or some of them, who cares? We know for a fact it blocks beta. We need to check heart rate and and blood pressure. Heart rate primary, blood pressure secondary, and then of course always be worried about the potential for affecting people with COPD and asthma, because we want to make sure they can have that bronchodilation when they need it. So that's how you'll immediately recognize these medicines. Again, they end in LOL. These ones that are, a lot of these actual beta blockers that are not also blocking alpha will end in OLOL. But just remember the LOL. If you see LOL at the end, you know it blocks betas. It may also block alphas, but we're really concerned about that beta. Non-selective. So there's 2 different types of beta. So we talked about non-selective adrenergic. Non-selective adrenergic means it blocks alpha and beta and all of it. Now if we're just talking about straight beta, non-selective means it blocks both beta 1 and beta 2. So that's your action. Blocks beta 1 and beta 2. Selective blocks beta 1 only. And why does that matter? So think about it. Let's think back to our chart about the beta 1 and beta 2. I told you the most concerning thing with beta 2 that you need to remember is bronchodilation. So if we block bronchodilation, we're potentially limiting the respiratory effects of people with asthma and COPD, right? Because that's what's caught. I mean, if they have asthma that they're already constricted there, we don't want to further constrict it by blocking the dilation. And then COPD, if they're already having trouble breathing, we want to dilate those bronchi as much as we can. We don't want to block that. So we would be very careful with people with asthma and COPD. So with the selective beta blockers, Metoprolol and Atenolol, yes, there are others, but these are the most common ones you're going to see. So therefore, they're the only 2 that I am testing you on, Metoprolol and Atenolol. So this is very simple, I think. If it ends in LOL, you know it's a beta blocker and you have to check blood pressure and heart rate, period. Right, period. That's it. If it ends in LOL, you have to check those 2 things. Now, next I need to think, is this selective or non-selective? And we've learned there's 2 different types of non-selective. There's a non-selective that blocks alpha and beta, and there's a non-selective that just blocks the 2 beta. Either of those, though, it doesn't, whether it's alpha and beta or just beta, if it's non-selective, we are concerned about people with asthma and COPD. If it's selective, it's a little more, it's more safe for those guys, right? It's safer for people with asthma and COPD. So look at it this way. You've only got 2 selective beta blockers that you need to concern yourself with for this class, Metoprolol and Atenolol, because they're the most common, hands down, the most common selective beta adrenergic blocking agents out there. If you see those 2, you know, okay, I got to check blood pressure and heart rate. We're probably okay for people with COPD and asthma. If it's not Metoprolol and Atenolol, now I know I need to worry about COPD and asthma. For our purposes in this class, that means it's not selective. When you get out into the real world, if it's not Metoprolol or Atenolol, you're going to look it up and go, is this selective or non-selective? Okay, it's selective, so we're okay. Or, oh, it's non-selective. I need to make sure that the doc's cool with this because this guy has a history of asthma and it seems like he's having, an increase in attacks. So, LOL, beta blocker, right? We know for a fact. blood pressure and heart rate. Heart rate is the most concerning. We're worried about that bradycardia, but we're also worried about blood pressure. And now I need to think, is this safe for asthma and COPD? And there's only two meds you need to remember for us, Metoprolol and Atenolol. If it's one of those two, we know it's selective. It's more safe for those people. I'm not saying it's perfectly safe. I'm saying it's more safe for those people. Non-selective is anything that's not Metoprolol or Atenolol. Okay, so if you're looking at something and you think, hey, I got an LOL, it's not Metoprolol, it's not Atenolol. I know I also need to think COPD and asthma, so I need to look that up and see if it's non-selective or not. Okay, hopefully that helps you. So for the purposes of our tests, Metoprolol and Atenolol are our selective beta blockers that we are concerned about. If you see that, it's more safe for asthma and COPD. If you see anything else LOL or any other LOL, you'll consider it non-selective and be cautious with those with COPD and asthma, and make sure you're calling the doc to see how that is, because a lot of times it's going to be contraindicated. Hopefully that helps, because it's a lot of terms, man, and I don't want you to get bogged down in these terms, because realistically no one does, right? When you get out into the world and you're working, you're concerned with what do I need to know to make sure I keep my patients safe. Understanding beta adrenergic, selective, non-selective adrenergic, and selective and non-selective total adrenergic, you can get a little confusing. So trying to break it down that way, LOL means beta blocker. I know for a fact it's blocking beta. I need to check heart rate, blood pressure. If it's not Metoprolol or Atenolol, I need to now worry about asthma and COPD. All right. Adverse effects of these, again, bradycardia and hypotension. Bradycardia primary on these. Hypotension though as well. They can cause hypotension, so we'll certainly be concerned. A lot of times docs though are okay going to an SBP down to 90. That does not mean that you do not talk to the doctor if it's SBP less than 100. You still talk to the doctor to make sure we're safe. But a lot of times the doc's like, yeah, we're cool, man. If it gets down below 90, then give me a holler. At which point you'll make sure that he puts that order in. So if you have that order, great, go with it. If you don't have that order, get the order before you give it. I'm worried when it starts getting down to around 100. I'm worried when it gets below 100. I'm definitely concerned and calling the doctor. Understanding though, sometimes the doc's cool with it being down below 90. Sometimes he's not. Sometimes they're like, no. And it depends on the patient, right? Some patients are more labile than others. But multiple times, even during clinical, there's been multiple times, even last semester. I remember a couple times in particular, patient's blood pressure was like 94. And we got lucky on this one because the doc just happened to walk in as we had the blood pressure medicine, as we had the beta blocker, and we checked blood pressure again just to see where we're at. And we're like, hey, doc, this is what's going on. And the doc's like, hey, you know what? I'm cool with them being down to 90. So at 94, I'm cool. And so we were able to put that in there, put the notes in there. Dr. So-and-so said, totally cool to give this medicine. Anytime you get those types of orders, make sure you put those notes in there and be specific. Doctor, exactly what doctor it is. Dr. Scratch and Sniff said this is totally okay to give down to this. Talk to him at this time, blah, blah, blah. And then try to have that doc put the order in if you can. The difference in adverse effects in these two, adverse effects of selective is bronchoconstriction. Big problem for COPD and asthma. So that affects our contraindications. Obviously with selective, we're worried about COPD and asthma. Both of these we're worried about diabetes, contraindicated in bradycardia, right? If the heart rate's less than 60, I'm definitely calling the doctor. I'm not giving it until I have an order. And usually, sometimes they'll let you go down to 55, and sometimes they're like, no, absolutely not. I don't want it given if it's less than 60. I'm going to check that. Patient teaching for beta adrenergic or for beta blockers. We talked about taking a pulse with the last beta blocker we talked about, which was total adrenergic blocker, but whatever. And that stays true here. We're going to teach them how to take their pulse. We're going to teach them these can cause dizziness, so stand up slowly. Don't stop abruptly, right? It can cause that rebound hypertension. We're going to discuss if they're diabetic, these can block those symptoms of hypoglycemia, so they need to be more careful about checking their blood pressure. Check your blood sugar. Check your blood sugar more regularly if you're diabetic. And some of these medicines, since they're sympathetic nervous, or since they work on the SNS, they can sometimes affect male sexual performance. And that can lead to an issue with compliance, right? If they notice that they're having trouble with sexual performance, they are less likely to be compliant at times. So we may want to warn them about that and to call the doctor if they start having those problems. There's things that maybe the doctor can help them with. So again, before we administer a beta blocker, if we see LOL, we know for a fact, LOL, boom, immediately think heart rate, first thing, blood pressure. Gonna check those two things. Now I need to determine, is it selective or non-selective? And for our purposes, Atenolol and Metoprolol are your selectives. They're more safe with asthma and COPD. If it's not Metoprolol or Atenolol, now I know it's non-selective. I need to really worry about asthma and COPD, right? So hopefully that helps with this, because these can be a little more confusing. Adrenergic agonists. So these are the ones that are going to actually activate those receptors instead of blocking them. When we're talking about adrenergic agonists, we're talking about sympathetic nervous system. So what's our effects on the sympathetic nervous system? Cardiovascular, right? We're worried about fight or flight, whether you're going to fight or you're going to run away, whatever you got to do to get yourself out of that situation as best you can. Your body needs more oxygen. So respiratory wise, we're going to dilate the bronchi, right? That oxygen's got to get to the tissues that need it, skeletal tissues and all that. So you're going to have an increased heart rate and increased contractility, and your blood vessels are going to constrict a little bit, especially your major ones, in order to get that blood to those tissues. As far as your eyes go, you need to be able to see the field of vision, so you're going to dilate, right? Those pupils are going to dilate, and that will also decrease intraocular pressure. Shock. We talked about this a little bit already. It's inadequate perfusion, right? It's just your blood pressure drops so low that your body's not getting enough oxygen to the major organs. Things start to shut down. Different types of shock. Cardiogenic shock, so your heart, either massive MI or certain drugs can cause cardiogenic problems. Heart's just not pumping enough. It's not able to function appropriately to get the oxygen to the tissues. Septic, so that is obviously an infection. It's a serious infection. Then it goes body wide. Your blood pressure crashes accordingly. It's just one of those things that occurs in this with sepsis. Any type of bacteria could potentially cause septic shock. You can have urosepsis. Any type of infection, bacterial infection, can cause it. Funguses potentially could, but it's not as common. It's mostly a bacterial thing. Hypovolemic is probably the most common shock, because this is a lot of times due to blood loss, right? Whether you've had an internal hemorrhage or someone's been in an accident where they've had damage to the vessels, to major vessels, or they've stabbed, shot, other things can cause it as well. You're just losing lots of blood. You can also get hypovolemic shock from dehydration, extreme dehydration. A lot of times that is caused by extreme diarrhea or vomiting. if they're not able to get those fluids back in them and make them back up, they can go into hypovolemic shock as well. Anaphylactic shock, this is just a severe allergic reaction, right? We get allergic reactions sometimes to things, but this is a severe allergic reaction where the histamines are just going crazy in its whole body. That's when we start to have the anaphylaxis with the closure of the throat, and that's when it gets real bad. That's when we can have very bad effects. So the way we treat that, one is we try to obviously dilate the bronchi to get as much oxygen in there, and then we try to get the blood pressure to come up as well, because that is with that giant histamine release, you're going to have decreased blood pressure with it. And the neurogenic is secondary to injury, usually to the spinal cord. It causes a disruption in those neural pathways. That disruption can cause a decrease in blood pressure and heart rate. So you can have an extreme decrease in blood pressure and heart rate, causing neurogenic shock. It doesn't matter what type it is. The bottom line is we have to get your perfusion increased, right? And the way that we do that right, the second anyways, is fluids, one, but also the big one is our Adenergic Agonists. So let's talk about those. So again, treatment, Adrenergic Agonists, we got to increase that heart rate and blood pressure. Dopamine, one of the ones that you'll go to probably first. It depends on the doc and the situation. But this increases heart rate, increases cardiac output, and therefore elevating blood pressure. Adverse effects. The problem with dopamine, obvious adverse effects, tachycardia and hypertension. But you expect that. You would watch it, make sure it doesn't become extreme tachycardia or hypertension. But it can also cause organ damage because, so we do increase our blood flow, right? Because we are increasing our oxygen, our oxygen intake, one, but also the blood pressure and heart rate. But we do that through vasoconstriction, right? And that vasoconstriction can become so marked that it actually decreases blood flow to peripheral tissues. So you may start noticing mottling of the hands and feet, decreased capillary refill. We can start to cause organ damage because of that. So we'll be really careful. If they're on dopamine, they're either in the ER or the ICU. End of discussion. You're not going to see this on the floor. Unless it was during a code situation, at which point that person's on their way to ICU. So we need to continuously monitor heart and blood pressure, and then continuously assess renal function. That's another organ that could be damaged by this. So we'll look and make sure they're putting out enough urine, and we're going to assess the peripheral capillary refill and pulses to make sure that those are staying steady. Dobutamine works very similar. Again, it's going to stimulate those receptor sites. This one has more of a preference for our beta-1 receptor sites. It still affects the others, but it really mostly prefers beta-1 receptor sites. So that is going to increase heart rate and contractility. The problem with this one, it can cause cardiac dysrhythmias. Any of these can cause cardiac dysrhythmias because of the way that they work. So they all have to be on a monitor. This one, though, seems to have a little more of an ability for that. So you'll certainly, again, these guys have to be in the ER or the ICU. You're doing continuous heart and blood pressure monitoring. Norepinephrine, this is when stuff has really hit the fan. This is when, oh my goodness, let's all start praying. We're going to give this medicine and we're going to pray. Or, whatever it is that you do. We're going to cause that vasoconstriction. This one is like, again, dopamine, dobutamine, they're not working. This is kind of our drug of last resort here. We're worried again about that cardiac dysrhythmia. This is norepinephrine. Norepinephrine, remember, is the stimulant for all of these. Alpha 1, 2, beta 1, 2. It's the natural one that we use. So we're going to stimulate all of that. So we're going to cause vasoconstriction, increased contractility, the whole bit. So we're worried about dysrhythmia. We're worried again about that organ damage because we're causing such vasoconstriction that your peripheral tissues and your renal tissues may actually have a decrease in oxygenation and a decrease in perfusion because of so much vasoconstriction. So watch for your urine output. Continue to do assessments on your capillary refill and all that. Look for modeling. Again, ER, ICU, that's it. That's the only place you're going to see that. It requires continuous heart monitoring and blood pressure monitoring. Epinephrine, this is the go-to for anaphylactic shock, right? A lot of people know about epi and EpiPens. For anaphylaxis, a lot of times we'll start with the IM. You can certainly give IV. IV epinephrine, though, is a code normally. It's most commonly given during cardiac arrest as far as IV goes. You can also actually give epi through, it's called racemic epi. You can give it through a nebulizer as well, but you'll mostly be concerned with the IM route. It's treatment of choice for anaphylactic shock, causes bronchodilation, right? We got to dilate those bronchi because that's a big part of anaphylaxis. And then also with that decreased blood pressure, we need to cause vasoconstriction, and that's what this is going to cause. So our adverse effects, we can potentially cause extreme hypertension, tachycardia. Most commonly, what you'll see is agitation, again, tachycardia. You'll see that. We just got to make sure it's not too extreme. And headache. You'll see headache with this as well. Patient teaching, as far as that goes, we're going to teach the patient, okay, so first we'll assess what was the allergy. What happened? And start looking for triggers. And so that's what we're going to teach them about, is let's start looking for triggers and how to avoid those triggers. They're going to probably need to carry around the EpiPen, so we're going to have to educate them on the EpiPen and how to use it, and the importance of, okay, you use this EpiPen to get you out of trouble right now, to keep you alive until you can get to the hospital. So it's not like, oh, you're feeling these symptoms, go ahead and take your EpiPen, then go to the club. It's you take the EpiPen, you call 911. That EpiPen will hopefully hold you long enough to get to the hospital. So we're going to teach them about that, how to use the EpiPen, and then go to the hospital after using the EpiPen. Another agonist is a beta 2 agonist. It's just a direct beta 2 agonist, and that is albuterol. You may be familiar with albuterol. It is a treatment of choice for respiratory distress. People are on albuterol. A lot of times it's a PRN, either nebulizer or MDI inhaler, and that causes direct bronchodilation because it affects those receptors right there. You will see this sometimes given, or sometimes people will take it every day as part of a maintenance routine in order to keep those bronchioles dilated. Again, usually, I've never seen it not given via a nebulizer or metered dose inhaler. So the big thing with nursing considerations there is to teach them how to take it. Alpha 2 agonists. So I told you we would talk briefly about this when we talked about alpha 2s. Clonidine is the medicine that we're talking about with this. Clonidine is most commonly used for PRN blood pressure control. You will sometimes see it as a maintenance blood pressure medicine, but not very often. It's They usually prefer other medicines. But the way this works is it directly stimulates those alpha-2 receptors. And if we remember right, alpha-2 is our regulatory receptor, right? It keeps norepinephrine in check so that we're not releasing too much norepinephrine, causing an overstimulation, which we've learned can cause bad things, right? If we're doing that, if we're regulating that more, if we're only stimulating that one receptor and able to regulate that further, that will bring down blood pressure. Think about it though, it also will regulate the rest of the central or the sympathetic nervous system. So it will also cause some CNS effects, most commonly drowsiness and sedation. So sometimes clonidine is actually used for those purposes, especially in the elderly, at least in my practice that I've seen. Sometimes they'll go to clonidine before they'll go to like a benzo, because benzos can cause some paradoxical effects, whereas clonidine, so if they're having some problems with some agitation, they may try clonidine to see if that will help regulate that person and help them through this time of agitation. It can also cause dry mouth, and then if you've been taking it for a while and you decide to stop taking it, it can cause that rebound hypertension. So again, our indication most commonly is a PRN for hypertension. It can also be given for maintenance hypertension, and then there are some times when we use it for agitation. And again, those adverse effects, drowsiness, sedation, can cause rebound hypertension and dry mouth. Contraindication, obviously hypotension. If they're already hypotensive, you wouldn't want to give this medicine. Be careful in people with a history of stroke or renal impairment or recent MI, recent myocardial infarction or heart attack. Interacts with other antihypertensives, can interact with MAOIs, which don't worry about knowing what an MAOI is yet. Just know that MAOIs interact with all kinds of medicines, and so we'll talk about those later. Also can interact with tricyclic antidepressants. Patient teaching. We talked about that potential rebound hypertension, so do not stop abruptly. May cause drowsiness or sedation. Avoid activities requiring mental alertness, right? So if we're giving them any medicine that could potentially cause sedation or drowsiness, we need to warn them, dude, don't drive. Don't do anything that needs your full awareness, right? Because if we're sedating them, we're decreasing their alertness and decreasing their ability to react. All right, so this is Perfusion 2. So we're going to continue our perfusion discussion. We're going to start with cardiotonic agents. So let's talk about heart failure. This is what we're using to treat, this is what we're using cardiotonic agents for. What is it? What is heart failure? And it's basically just the impaired pumping or filling of the heart. There's different types of heart failure. There's left ventricular, right ventricular. Usually what happens though, no matter which one you start with, and again, left is the most common. It used to be called congestive heart failure. And you'll still see that term from time to time. The bottom line is, whether it's right or left, eventually because it's a chronic disease and it continually gets worse. Our goal is to just help slow it, right? Eventually both sides will be affected, because when one side's affected, the other starts working or starts becoming effective eventually. Symptoms, shortness of breath, fatigue, edema. You may notice crackles in the lungs, some peripheral edema as well. Some causes. What is it that causes heart failure? Hypertension is a big cause. Probably the leading cause they'll state in books is your coronary artery disease. Diabetes is a potential cause of heart failure. Valvular disease can cause heart failure. It could also just be idiopathic. We don't know what caused it. They just ended up with it. There can be cardiomyopathy, so damage to the heart from infections or from medications or drugs can cause cardiomyopathy. And scary enough, but also postpartum. So being pregnant. Afterwards, you can have what's called postpartum cardiomyopathy, and I've seen one case of that. And it was devastating. This young lady, she was young and just had a baby and super excited about life, but was having these vague symptoms. They were getting a little more pronounced, and by the time she got to us, she was having some pretty marked postpartum cardiomyopathy. Scary situation for this person. So first step of treatment, we talked about this with hypertension. Non-pharmacological interventions, non-pharmacological treatment. Some ways that we do that: limit intake of salt, limit alcohol or just stop drinking, quit smoking, and try to increase your exercise, increase the strength of the heart that way. The thing with exercise, and for these guys, talk to the doctor, because you don't want to go out there and just go crazy with it. You need to gradually work your way up. It can be dangerous to just go out and immediately start exercising without any guidance. Other treatments for alcohol, or for I don't know why I've got that on my. Other treatments for heart failure, ACE inhibitors. We talked about ACE inhibitors already. They decrease the workload because we call that vasodilation. That decreases the work that the heart has to do. If we can do that, that will help with the heart failure. Nitrates do much the same thing. We'll talk about nitrates here in a little bit. Beta blockers, we talked about beta blockers, again, decreasing heart rate, decreasing the workload. Diuretics, because we start to get that congestion, so the diuretics will help decrease the blood volume, getting rid of that edema. We use diuretics in exacerbations. That's the go-to medicine for exacerbations. So if you catch that exacerbation early enough before it starts to become full-blown, when they're starting to have those early symptoms, which a lot of times that early symptoms is a little bit of shortness of breath or crackles in the lungs. You'll hear those real fine crackles a lot of times before they even show any other symptoms. If you can catch those early, we can get them some diuretics. Most commonly, it's a loop diuretic like furosemide. We give them a little bit of that, and that will help get that excess fluid off and keep them from going into a full exacerbation. As a home health nurse, that was a big part of my job. Was when I went out and assessed patients, I would really do a real fine respiratory assessment, just to really listen for those crackles. Multiple times I was able to pick those up and say, okay, let's take an extra Lasix, okay, and then we'll talk to your doc and go from there. I'll follow up with you tomorrow. And stopped multiple exacerbations that way. And then cardioglycosides, which is your digoxin, just a fancy word for digoxin. This is going to increase the contractility of the heart. Digoxin is not a go-to first-line medicine usually, unless they've already got marked heart failure by the time that they get diagnosed. It's usually one of the later medicines. The more common upfront medicines, diuretics, number one. That's where they're definitely going to be put on that. Beta blocker and ACE inhibitor a lot of times are the ones that they'll start with. And then they'll go to digoxin usually later. Not saying that you won't see somebody with brand new diagnosis that's put on digoxin. It's just in my practice what I've seen is usually that's a later medicine. The action of digoxin. We talked a little bit about this when we talked about calcium channel blockers because these act in the opposite way, right? These work by increasing intracellular calcium, right? So we force more calcium into the myocardial cells. By doing so, that increases the force of contraction. Now, I know what you're thinking, and this is where it gets confusing. Calcium channel blockers blocked calcium from entering the cell, therefore decreasing myocardial contractility, also decreased the heart rate, right? So you would think digoxin would do the exact opposite. It does as far as the contractility is concerned. It instead of decreasing, it increases. So digoxin increases the force of myocardial contraction. However, it too decreases heart rate because it works on the conduction of the AV node. And it decreases that conduction through that node, therefore causing a decrease in heart rate. So calcium channel blockers decrease myocardial contractility and decrease heart rate. Digoxin increases myocardial contractility but also decreases heart rate. When we increase myocardial contractility, we increase cardiac output, we increase renal perfusion. When we increase those two things, think about what goes with it. If we're increasing renal perfusion, so we're increasing the amount of blood that's going to flow through the renal system and the pressure of which that's going to, or the output of which is going through there, that is going to increase urine output, right? So increased force of myocardial contractility, increased cardiac output, increased renal perfusion, increased urine output, and slow heart rate. That's what they do. Indication: heart failure and also atrial arrhythmias. You will see this for people. So some people may be on this that don't have heart failure, but they've got AFib. That makes sense because we do use these for atrial arrhythmias because, again, remember, it's slowing that conduction through the AV node. And what we know about that is when you have AFib, the SA node obviously is not working appropriately. So the AV node's being relied upon. And unfortunately, that can get out of control. It's called uncontrolled atrial fibrillation. That can be very dangerous. Uncontrolled atrial fibrillation means your atria are just going nuts, and they're contracting probably a lot. They're contracting all the time, causing your ventricles to fire at various times, and all that, even though it's contracting a lot, it's not so it's not a full contraction. It's not like the AVs are just kind of, they're fluttering, I guess. So they're not, it's not even really right to say they're contracting a lot. They're just fluttering a lot. They're not able to push all that blood into the ventricles, so that blood can sit there in the atria, and that when blood sits, it causes clots. And eventually one of those clots can get down into the ventricles, and then we have a serious situation because that ventricle is still going to contract and send it out into your body and can go to your lungs or your head. We can have a stroke or a PE. We have a devastating effects. So we got to control that. Atrial fibrillation, one way we control it is through digoxin. Adverse effects. The big one is bradycardia. That's the big one. That's the one that we're really concerned about. Anytime we're going to give digoxin, we are going to check a pulse, and this one has to be apically. We're going to check for a full minute apical pulse before we give digoxin. If it's less than 60, we are not going to give the digoxin. We are going to call the doctor and let them know. Another thing we're worried about is anytime we give a medicine that could potentially be an antiarrhythmia, it can cause an arrhythmia, so we'll watch for that. Watch for dig toxicity. That's another potential issue with digoxin. It's got a narrow therapeutic range, and we talked about narrow therapeutic ranges a few PowerPoint notes ago with our first one there. What we know about narrow therapeutic ranges, we need to worry about lab work and watching that those levels and making sure they don't become toxic. Dig toxicity. Therapeutic range is normally 0.5 to 2. Now, when I say that, inevitably you're going to have docs that have different ranges, and that's fine. Basically, it's 0.5 to 2. Some docs may be like, no, 0.8, 0.5 is not enough. And, maybe I'll go a little bit higher than 0. But for the most part, for your purposes, it's 0.5 to 2. Toxicity, though, is 2.5. So you can see that's a very narrow range. If 2 is the higher level of therapeutic, and maybe that's where some people are to be therapeutic, yet 2.5 is toxic, you can see where we can get into a lot of trouble. Toxicity, a lot of times you'll start seeing headache, bradycardia, vision changes. What the vision change that's most commonly associated is a yellow halo. You'll start to see like a yellow halo. Toxicity can become devastating, so that has to be taken care of. When they have bradycardia, that can be one of those early warnings of toxicity. So if any time that the heart rate's less than 60, the doc needs to be called. Do not give the med until you talk to the doc. He may say, just let's hold it and get a dig level. He may say, let's just hold it for a few days and see what the heart rate does, whatever. Bottom line is heart rate apical. If the apical heart rate's less than 60, you've got to hold it and call the doc. And then, of course, so before we give dig, we know, just based on what we have figured out so far, again, adverse effects, bradycardia, arrhythmia, dig toxicity, so headache, drowsiness, vision changes. We know, just looking at that, we have to check apical heart rate and dig level before we give them digoxin. So we need to know, when was their last dig level. It's not something you do every day. And if they've been on dig for a while, they may only do it every so often. But it needs to be checked. And I want to know what it was last time and when the doc plans on doing it again before I give the dig. And I'm definitely checking an apical heart rate. Contraindications. So obviously bradycardia. If they're bradycardic, we're not giving it. Also, acute MI. We wouldn't want to give it for heart block. Heart block is certainly leading to, it's usually heart block goes hand in hand with bradycardia anyways, but we would be careful of that. And if they currently have a ventricular arrhythmia, this is not a go-to med for that. There's other meds that actually we'll talk about towards the end of the semester that are for ventricular arrhythmias. Be careful in people with renal insufficiency. Be careful with hypokalemia, actually. These can affect potassium. We want to make sure we're careful. We're going to check potassium just to see, and we'll be really careful with people with hypokalemia. We'll even be careful with hypocalcemia, because think about that. If they don't have enough calcium, it's going to be hard to shove calcium into the heart. Interactions, diuretics, ACE inhibitors potentially. As far as patient teaching is concerned, there's quite a bit we need to think about. One, heart rate. We've got to teach them the importance of heart rate and how to check their heart rate. And then notify the provider if their heart rate gets less than 60. Notify them about the potential for dig toxicity and what to look for. Certainly we don't want to scare them, but we want to say, hey, look, this medicine is very important for you. Here's how it's going to work. So we're going to teach them about how it works. There is potential, though, to get a little too much of this medicine. So if you start noticing that things start looking yellowish, or it's, there's like a yellow halo around some things, you start noticing, you don't feel right, your pulse is low, headache, things like that, then let's call the doc and get a dig level checked. With that, we'll teach them about when their next dig level is due. Whenever the doc says, okay, I want to see them in this many weeks or months or whatever it is, we're going to check your dig level at that time. They need to know that. They need to know to keep that appointment. They need to understand, again, anytime we're looking at the potential for narrow therapeutic range and potential for toxicity, they need to know how important it is to take that medicine at the same time every day. So let's say they are to take it at 9 every day. As long as they're taking it sometime between 8 and 10, they're probably going to be okay. If it's turned into, noon, 1 o'clock, and they forgot to take it, they need to call their doc and see how the doc wants them to handle that. Because if they did take it like around 1 and then took it the next day around 8, there's a potential there, obviously, to cross over that narrow therapeutic range and cause some problems. So it's really important for them to understand the importance of taking this on time, every day, which is usually in the morning, because, again, this is going to increase renal perfusion, can increase some urination. Do not take the missed dose. If they, let's say the next day, they're like, oh my God, I forgot to take my DIG yesterday, I'm just going to go ahead and take 2 now. No, that's not how this medicine works. They need to call the doc and let them know that they missed a dose and see what the doc wants to do from there. But do not take the missed dose. If they get, let's say they get to nighttime and are like, oh my God, I forgot to take my DIG this morning. Again, contact the doc, let them know, or, don't make that missed dose up. You need to get some guidance. Again, they're going to need to know when to do their blood work, when to watch from when the doc's going to monitor their levels. It can interact with certain OTC medicines. PPIs is one, proton pump inhibitors, that can increase DIG levels. Aspirin and Nsaids can also cause some problems anyways. Those are all over-the-counter medicines. So basically don't take any over-the-counter medicines until you talk to your doctors. Let's just stick with that. Don't take OTC medicines without consulting your doc, because PPIs like omeprazole, pantoprazole, aspirin, NSAIDs like ibuprofen and naproxen, those can all cause problems. And then that's basically it. Notify your provider of nausea, vomiting, vision changes, those types of things. Low heart rate. We're concerned about DIG toxicity. We talked a little bit about toxicity signs and symptoms already, so let's go a little deeper there. That yellow halo is a big deal if they start noticing that. Bradycardia is one of those early signs that you may note. There's GI symptoms, nausea, vomiting. They may even just not feel like eating at all. May notice a little diarrhea. Mental status changes definitely are associated with DIG toxicity. They might notice some more confusion, headaches as well, and then bradycardia, like I talked about. There is an antidote for it. So again, our normal levels are usually 0.5 to 2. You might see 0.8 to 2, fine, whatever. That's whatever, fine. Toxic levels classically are around 2.5. You'll see some books that say anything over 2. The bottom line is it's a very, very narrow therapeutic range. So we need to watch it. The antidote is going to bind with the digoxin itself and reverse the toxicity. And it's called digoxin immune fab. So just the word digoxin, the word immune as an immune system, and the word fab, F-A-B, fab, okay, fab. So digoxin immune fab.